Alhamdulillah, wa salatu wa salam ala Rasulillah. Good evening, a very good evening for all of the attendants and for those who will join later. It is a great pleasure for me to address you tonight in a talk that I have prepared primarily for the registrars, and I will upgrade it to enjoy its participation of the attending consultants. I prepared it for the registrars in two ways. In one way, as a problem-based learning fashion, and the other thing, I know people who are going to sit for examinations are examination-oriented. So I hope we are going to have a lot of interactions between myself and the registrars, and we do welcome the comments of the consultants. The talk today will be an upper abdominal pain, but I will redirect it towards the biliary system. I have enjoyed the previous talks. The first was on the biliary surgery in the COVID-19 era, and the second one about cholecystectomies, laparoscopic cholecystectomies, and laparoscopic surgery for the biliary system presented by Professor Ahmed from the UK. In fact, I think there are some debatable issues we are going to discuss, but I am intending to present it to suit the situation in Sudan. So I will start with a scenario of a problem. I made a scenario of a 46-year-old male patient who came complaining of recurrent upper abdominal discomfort after meals. And in the last few days, he couldn't tolerate food, and the pain became agonizing. Last night, he developed fever with chills. He gave a history that last month he has severe pain for which he was hospitalized for 5 days and was put on analgesics and intravenous antibiotics. And he improved, but he discharged himself against medical advice. He didn't disclose why he discharged himself against medical advice. Probably this point is interesting. Anyhow, he is an ex-smoker. He is hypertensive on amlodipine 10 milligram daily and beta blocker, bisoprolol 5 milligram tablets once daily. And he is diabetic on Amaryl tablets 2 milligram daily and metformin 500 milligram tablets daily. Also, he is taking his routine drugs for diabetes and hypertension, and these are atorvastatin 20 milligram and aspirin 100 milligram daily. And for pain, he is on hyoscine tablets and diclofenac tablets, PRN. Now, question and answer. For this history, what would our honorable registrar think the case will be? I just made a little introduction, and now what would be the differential diagnosis for a patient who is 46 and he has got an upper abdominal pain related to food, and it was increasing. He has past history of hospitalization for 5 days, but last night he has a fever with chills, and he is diabetic and hypertension. Can anyone give us our opinion? What is the differential diagnosis? What is the working diagnosis for us to continue with this patient? Anybody to participate? Is the voice clear? Do
Yes,
you hear me?
the voice is clear.
It's clear. So we can give some more hints. If anyone would like to participate, yes, please. We can give some more hints. The primary investigations done for him showed that he has got a high white blood cell count of 22,000 and hemoglobin at the upper limits of normal, that is 17 gram per deciliter. His total bilirubin is raised 7.5, direct 4. And his liver enzymes were all raised. These are alkaline phosphatase, AST, and ALT. But his total protein is a little bit low, and albumin is definitely low, 2.6 gram per deciliter. His urea, upper limits of normal, 50 milligram per deciliter. Creatinine is raised, 2.2 milligram per deciliter, with low sodium, 122 millimole per liter, and potassium also is low, 2.9 millimole per liter. But his uric acid is raised, 10 milligram per deciliter, and his blood sugar is also raised, 350 milligram per deciliter. Can somebody say anything about these symptoms and the elementary blood tests done for him?
Hello, Prof.
Yes, please.
This may be a feature of ascending cholangitis because in the history,
Ascending cholangitis because of?
He complained of fever with rigors and fever.
Fever with rigors?
Yes. And also there is an increase in the total white cells.
White cell count is high?
Yeah. Also there is an increase in the bilirubin.
Bilirubin is high.
Yes.
Mostly direct bilirubin.
And alkaline phosphatase.
And alkaline phosphatase. And what about the renal profile? Does it reflect anything, the renal profile?
This may be complicated, the complication of the like the hepatorenal syndrome
it is not a
or dehydration.
Hepatorenal syndrome usually it occurs in portal hypertension, but this is the effect of the high bilirubin. Does the high bilirubin, does obstructive jaundice affect the acid-base balance? Do jaundice patients has any derailment in their acid-base balance? Are they alkalotic or acidotic? Patients with jaundice. I am now discussing principles of surgical practice. These are the principles of surgical practice. Surgical practice does not mean operation. There is principles of surgical practice, there is surgical pathology, and then there is operative surgery. And now we are just in the principles. And I mentioned at the beginning, I am directing this talk towards the registrars. Jaundice patients usually are alkalotic. Bile is alkaline. The pH of bile is more than 7. And in a state of alkalosis, potassium enters the cells and the serum potassium become low. The serum potassium in a state of alkalosis become low, and his potassium here is 2.9. Probably sodium is dilutionally low. His creatinine is elevated. Why is it elevated? Any suggestions? Remember, the patient is hypertensive, diabetic, and now he is jaundiced. And his uric acid is 10. All these factors together can raise his, can deteriorate his renal functions, can raise his creatinine. The high uric acid, hypertension, and diabetes, and bilirubin. And bile salts also might precipitate in the tubules, in the glomeruli, and can destroy the nephron. And the blood sugar is high. Why is it high? Does it give any impression? Has it got any explanation? 1 month ago, he was in hospital and he received treatment, but probably has got a poor control of his diabetes. Usually diabetes is poorly controlled in cases of infection. And you have correctly said this could be a case of cholangitis. Now let us move forward. What is the differential diagnosis? Now we are coming to the proper diagnosis. What is the differential diagnosis? Cholangitis due to what?
CBD storm ممكن.
It could be common bile duct stones due to obstructive joint, due to common bile duct stones. Any further suggestions?
Or maybe due to tumor, cholangiocarcinoma.
It could be cholangiocarcinoma. And any further differential diagnosis? With this fever with Rikers, could it be cholangitis? Or could it be empyema gallbladder with a stone obstructing the neck of the gallbladder and compressing the common bile duct? We know cases of Meniere's syndrome. And as well, it could be a cause of any obstructive jaundice. If we state cholangiocarcinoma, first we have to say carcinoma head of pancreas. So common bile duct stone comes first, and empyema gallbladder with the stone obstructing the neck of the gallbladder and pressing on the common bile duct, carcinoma head of pancreas, periampullary carcinoma, and CBD stricture due to cholangiocarcinoma. Now, physical examination. When we talk about physical examination, you have got a splendid lecture before on biliary surgery in the era of COVID-19. And by now, it should be very clear how we examine patients. Do we examine patients? What do we do before examining patients? At this stage in our life with COVID-19 is still spreading around. Are we going to examine him? Or are we going to do anything else? In the past, and hopefully in the future, we're going to go back to examine the patient from head to toe. From head to toe. We should not forget to examine his neck for lymph nodes, and we should not forget to examine his chest. He is an ex-smoker. And we should not forget to examine his heart. He is diabetic and hypertensive, and he has got probably some chronic pulmonary disease from his smoking, previous smoking. So, and at the time when COVID-19 is spreading, one should eliminate chances, most likely to eliminate chances for examining the patient, and should go directly for investigations. We have done the blood tests, and we should go for some further investigations. Can anybody suggest what further investigations should we ask for? And this is not the time to examine the chest by a stethoscope, which is 30 centimeters long. The nose of the examining doctor will be something about 40 centimeters from the nose of the patient. If he coughs or sneezes, it is a great problem. So what shall we ask for further investigations for this patient?
PCR for the COVID.
PCR for
COVID-19.
COVID-19. What else?
CT chest.
CT chest, X-ray chest or CT chest, and inflammatory markers. And
Abdominal
specific investigations should be, usually the investigations should be divided into 3. Investigations to diagnose the case, for diagnosis. And the second line of investigations is to see the effect of the disease on the body. And the third type of investigations is to see if the patient is fit for surgery, provided that surgery is indicated. So now we have done blood tests, and we would like to go further to confirm the diagnosis. You have mentioned correctly the differential diagnosis. Now we want to confirm it. What investigations should we ask for
MRCP.
Please. Usually surgeons are bold, they should say things. And in surgery, 1 + 1 is not always equal to. And there is a lot of debates on things. The most important thing is to defend yourself. And I will mention a lot of points with discrepancies to what was previously said in the previous lecture. And then we will see how people defend themselves. And this will be your attitude during examination. Your answer, you should be able to defend your answer. Whatever answer it is, it will be acceptable and it will be correct. Usually there are different opinions and different methods. So now we want to confirm the diagnosis. We know he has got obstructive jaundice, but we don't know what is the cause of obstructive jaundice. What shall we do?
Abdominal ultrasound.
Abdominal ultrasound. Very good. Most likely, we think in abdominal ultrasound, we are looking for gallstones, right? And most of you know the etiology of gallstones. You know how gallstones form, right? Gallstones form when there is discrepancies or when there is disturbance of the equilibrium between phospholipids and cholesterol and bile salts. If there is high concentration of cholesterol, patient might form cholesterol stones. If there is infection as well, might develop mixed stones. And if there is reasons for hemolysis, like malaria, the commonest cause of hemolysis in Sudan, he will have small black stones, pigment stones. Anyhow, we are thinking of obstructive jaundice due to gallstones. And at this moment, I will say that the incidence of common bile duct stones in patients with gallstones is 5 to 15%. Let us say 10% of patients with gallstones have common bile duct stones. Let us imagine that 10% of our patients with gallstones have common bile duct stones. The most important thing is that this 10%, which is 5 to 15%, who are having common bile duct stones, the vast majority are symptomatic. They will cause biliary colic and jaundice. However, 5% of them will be asymptomatic. 5% of them will be asymptomatic. And this is the trick. If we find in ultrasound common bile duct stone, but the patient is never complaining of abdominal pain, he never experienced any abdominal colic, and he has got a normal appetite, he tolerates fatty meals, and he has no problem at all. What shall we do for a silent asymptomatic stone in the common bile duct? Probably this should go towards the consultant. They can comment on it. Anybody would like to participate? Asymptomatic common bile duct stone. What shall we do for it? From time to time, we see patients with common bile duct stone and he has no complaint at all. I have just said you have to defend yourself. One can say, I will remove this stone by ERCP or by open cholecystectomy, open surgery, or by laparoscopic surgery. And the treatment is removal of the common bile duct stone. But he has to defend that. And some might say, I will not do anything for it. Leave it alone. And the answer could be correct. You should also defend the answer. The voice is not clear. Probably some people are.
Mr. Suleiman, you're welcome. Mr. Suleiman Hussein.
Welcome, Prof. Welcome, Prof. Suleiman. Somebody who has got a silent gallstone, let us take two scenarios. A patient who is elderly with chronic obstructive heart disease, lung disease, or with ischemic heart disease, or he has got any other, he has got a CVA. Are you going to remove that asymptomatic common bile duct stone? No, no need to interfere in a patient who is severely ill and has got asymptomatic CBD stone. He has no jaundice, he has no abdominal pain, he has another problem, CVA or heart disease or chronic lung disease or renal failure or anything. On the other hand, in an adult who is fit, or even a patient who is 60s and fit, if we leave a common bile duct stone, one day symptoms will increase with time and complications will increase with time. We should not wait till he becomes 70s or 80s and develop cholangitis. Cholangitis is a killing disease, it's a very serious disease. So in those who are fit, have no comorbid diseases, we should remove the common bile duct stone by whatever available method, If you have ERCP and the stone is easy to be removed, 5 millimeters or 6 millimeters, or if the person who is doing ERCP has manual lithotripsy, he can crush the stone, I will request that to be done for him, provided the patient can tolerate that and is fit. Otherwise, to go for surgery, cholecystectomy, and CVD exploration and removal of the stone. Because if we leave a common bile duct stone, with time, the incidence of complications will increase in all types of gallstones. Complications will increase with age. Now, let us also see. Generally, common bile duct stones are serious. What are the complications? Just tell me two serious and very common complications of common bile duct stones. The commonest complications, two commonest complications.
Pancreatitis.
Pardon?
Acute pancreatitis and acute cholangitis.
Acute cholangitis and ascending cholangitis. Very good, excellent. Excellent. Cholangitis and acute pancreatitis. In acute pancreatitis, probably also this question should go to the fourth class registrars, or some consultant might participate. A patient with cholangitis, with acute pancreatitis, shall we request for him an ERCP to remove the stone, or shall we treat conservatively?
It's preferably actually to not to attempt an ERCP, as it's going to worsening the acute pancreatitis unless the patient having acute cholangitis plus the acute pancreatitis.
Super excellent. Yes, no ERCP unless the patient has got a persistent obstruction. Probably the stone has caused obstruction and it left, it went out. Why should we fiddle around the pancreatic duct? And ERCP is not without complications. ERCP is not without complications as well. Now, this patient, we said he has, last night he has got fever with chills, and his temperature was more than 37.3. I just wrote it in red to tell that the cutoff for the normal body temperature, is 37.3. Above 37.3, the patient has fever. 37.3, unless the patient usually does not have fever. And this is a cutoff. And with leukocytosis means there is a severe inflammation or infection. And all of you know the Charcos triad. The Charcos triad is fever, jaundice, and pain. Now, from this message, from this talk up to now, I would like just to say that my message is any patient who has gallstones and raised liver enzymes, just think that he has got common bile duct stone till proven otherwise. Any patient who has got stones in the gallbladder, any patient who has got stones in the gallbladder with raised liver enzymes, you see, I did not mention total or direct bilirubin, you know this point. But if there are raised liver enzymes, just eliminate presence of common bile duct stones. Don't go and think this is hepatitis at all. First thing is to eliminate common bile duct stone. Frequently we see things like this and we think probably he has hepatitis and this or that. No, we have to rule out. We said this patient last month was admitted to hospital for 5 days and was put on IV fluids and analgesics and antibiotics, but he left the hospital against medical advice. Could that admission be pancreatitis? And if so, what shall we do for him? Could the previous admission be pancreatitis? Was admitted for 5 days. Yes, please. If he was admitted 1 month ago with pancreatitis, can we have any evidence now the previous admission was pancreatitis? Is it possible to have any evidence now? We know the diagnosis of pancreatitis depends on presence of high serum amylase more than 1,000 units per liter. The cutoff is 1,000 and after that it will drop, it will be filtered in the urine. And lipase will be also high, it will be diagnostic, but after 1 month it will come down. But is there any possibility that we might find something to tell us the previous admission was pancreatitis?
Imaging may show evidence of previous with pancreatitis.
Like?
CT may show calcifications to the system.
Calcification is
necrosis.
More common in chronic pancreatitis, of course.
Yes.
Pancreatitis for 1 month. Yes, it can cause complications and anything else.
Pseudocyst.
Yeah. Pseudocyst. We might see pseudocyst. And if there is a pseudocyst, usually, do we operate immediately or do we wait for surgery? If there is a pseudocyst, we should wait for a period of around about 6 weeks for the cyst wall to mature to hold sutures before we do any surgery, any gastrocystostomy. Anyhow, we go forward. We have done ultrasound, and this is the picture of the ultrasound. It showed common bile duct a little bit more than 7 millimeters with something calcified here and echogenic shadow here. Could this be a stone? Could it be calcification? Could there be a tumor here? This is the most distal part of the common bile duct. The normal common bile duct should not be more than 7 millimeters. 7 millimeters is the upper cutoff for the diameter of the common bile duct. More than 7 means it is dilated. It means that if something has obstructed the common bile duct before, or now it is obstructed. And he has got something here, calcified, could it be a stone? And it is throwing shadow here. Can we confirm ultrasound? In fact, it is the sensitivity of ultrasound to detect common bile duct stone it is operator dependent, correct? But the sensitivity is around 65%. In 65% of cases can tell us that there are common bile duct stones. Means we are going to miss 35%. And specificity is 60%. In 60% can say, no, there are no common bile duct stones. Only in 60%, only. So what shall we do more to confirm that this is a stone or to confirm that this is not a stone? What further investigation?
imaging like MRCP.
Excellent. Super. This is a MRCP. You remember the previous lecture by Professor Ahmed Nassar? I do respect him. He is working in a center of excellence, but he mentioned he doesn't do MRCP, he doesn't do ERCP, and he goes ahead for exploration of common bile duct, and all the time he do it laparoscopically. I think in our setup, this is rarely found. Few surgeons, they go for exploration of common bile duct stones. Among them, Mr. Sami Dirdiri, he mentioned this name. He did it several times. Some other surgeons have done it, but it is not always available in all centers, private or governmental hospitals. So this is our ERCP, and it shows clearly that the common bile duct and intrahepatic ducts are dilated, grossly dilated. There are shadows within the gallbladder, and there is a filling defect with convexity. With convexity, most likely it is a stone. Most likely it is a stone. The common bile duct, the common pancreatic duct is prominent. And now to see an MRCP, we do not only see this view, we have to see the coronal views. Let us go to the coronal views. This is the most distal part of the common bile duct. It shows multiple filling defects with the fluid, the bile, going around them and separating them from the wall of the common bile duct. It means that this is not a tumor, and they are multiple. This will confirm that these are stones. But why ultrasound does not diagnose 100% common bile duct stones? These are multiple stones impacted at the distal end. What covers the distal end of the common bile duct? There are two anatomical structures containing gas that obliterate the shadow of a stone at the distal end of the common bile duct. What are these organs containing gas sitting just anterior to the distal end of the common bile duct? I think this is a very easy question. No?
The second part of the duodenum and the transverse colon.
Yeah, the duodenum and the transverse colon. This is the reason why ultrasonographers find some difficulty in detecting stones when they are impacted in the very distal end. And MRCP is good. This is in contradistinction to what has been said before. MRCP is, anyhow, MRCP is a good tool. And it is easy and it is harmless. Now the second message is that the distal area of the common bile duct, where stones usually impact, they are usually obscured by gas in the duodenum and colon. This is why we request an MRCP to confirm the diagnosis. Now our patient has got impacted stones at the distal end of the common bile duct. In fact, MRCP diagnoses stones in the common bile duct with an accuracy, with sensitivity of 95%, in contradistinction to ultrasound, which is only 65%. And its specificity to say no common bile duct stones, 90%, compared to ultrasound with a specificity of only 60% to say that there are no common bile duct stones. So it is superior. It's not only superior, it is a non-invasive investigation. It can be performed rapidly in the same day or next morning. It does not expose the patient to ionized radiation, not like the CT scan. It does not expose the patient to iodinated contrast. So there is no chances for allergy. Why should we refuse MRCP? And now this is a beautiful picture. In fact, it is so beautiful that one can do a laparoscopic cholecystectomy when he is under training, and just by grasping the fundus and pushing it upwards towards the right shoulder, and the Hartmann pouch anteriorly and laterally, we'll see a beautiful thing. But in such a beautiful picture can pull the common bile duct and can clip the common bile duct itself. This is a very normal, very narrow common bile duct, very easy to be pulled and clipped. And in fact, a lot of injuries occur in these simple cases, simple cholecystectomies. Anyhow, now the patient has definite distal stones, distal common bile duct stones, with the disturbed blood levels of everything, of his renal profile and his liver profile and his blood sugar. What should we do for him? What is the next step? Till now, we are speaking about the principles of surgical practice. A patient who has got abdominal discomfort, pain, previous admission, probably it was pancreatitis, and he has got disturbed liver function test, renal function test, high blood sugar, and now we have confirmed that he has got distal common bile duct stones. What should we do for him?
The most important thing is to drain the obstructive biliary system and to control the source of the sepsis by ERCP.
Very good. Control the source of sepsis by ERCP and by antibiotics as well, right?
Yes.
And,
yeah, antibiotic and IV fluid
and
rehydration.
remove the stones. And remove the stones. But before going to ERCP, are we going to do anything? We need to admit him, right? Let us go step by step. We are going to admit this patient and we are going to control his blood sugar, right? Probably we are going to request a physician to do that for us, or we do it ourselves if we are in a small hospitals and not much of a doctors to look. We can put the patient in insulin sliding scale to control his blood sugar. We give him intravenous fluids because he has got a high creatinine. What type of fluid shall we give him? Dextrose 5%, dextrose in water, or normal saline, or ringers like that. What shall we give him? Yes. We will have a small break and then we will continue. But now we are going to continue a little. The break will come in a few minutes' time for prayer. What shall we do him? We are going to admit him. We are going to put him in insulin sliding scale to correct his blood sugar. We are going to give him normal saline, right? Normal saline. Patients with renal impairment, we do not give them dextrose in water. We give them normal saline. And probably we have to give him potassium to correct his low potassium. And probably we have to correct his low proteins. But we should go as early as possible for ERCP, as you have correctly said, to remove the stones, drain the biliary system, and give him antibiotics. Pain will disappear spontaneously. So the answer was ERCP, to drain the biliary system. And even if a retrieval of stones is difficult, they can just put for us a stent. ERCP has got significant mortality, 1%, and has got morbidity, 7%. Morbidity, 7%. ERCP can cause posterior perforation of the duodenum, right? And it can cause cholangitis. And it can cause pancreatitis. So, as I said before, in medicine, 1 + 1 is not always right. You have to defend your answer. ERCP is the correct answer. But if the patient has previous gastric surgery in the form of Burris II or gastrectomy, or when we have a previous session done by Dr. Balila, the surgeon, if he has got distal gastrectomy, or if he has got a hepaticoenterostomy, we are not going to request for ERCP because they cannot cannulate, they cannot reach the ampoule of water to cannulate it. Anyhow, you should put that in mind. In fact, I went just for an old review I have done with one of my colleagues, Mr. Nasruddin Adam. When we reviewed the ERCP at Ibn Sina Hospital, at that time, it was in 2010, for 119 patients. And there were 11 patients with missed stones, and some patients, they failed to retrieve their stones. In fact, missed stones after surgery were 11, but some physicians and surgeons have referred patients to Ibn Sina with common bile duct stones. So the number of patients with common bile duct stones is more than 11, but they failed to remove some of the common bile duct stones. And out of the 119 patients, few patients developed complications. Two, they developed perforation, posterior perforation of the duodenum, and we had to operate them at that time. And one had an impacted tip of the dormia inside, and we have to operate him to remove that dormia. And two had bleeding. They received just blood and they improved. And one has got cholangitis, and probably quite a few, they developed transient pancreatitis. Their success rate was 66% in 79 patients. I think the experience is now far more better. And I will be glad to see my colleagues, Mr. Nasser Al-Habboub and others who are at Ibn Sina Hospital now, and to tell us what is the situation now, what are the morbidities of ERCP in that governmental hospital. And this is a photo of the X-ray film. ERCP was done. The question is when to operate. ERCP was done, common bile duct stones were removed. When shall we go for cholecystectomy? Timing of cholecystectomy. We do welcome our dear consultants to participate. And I think the question will be for the senior registrars. Usually, poking the common bile duct in the posterior abdominal wall in the retroperitoneum, it induces a lot of edema and inflammatory process. Either we have to operate on the same day or next day, or to wait something behind 7 days, something more than 7 days, to let the edema to subside, and then we operate. Otherwise, we are going to find some difficulty in dissecting in the Callot's triangle. So after ERCP, the decision is to operate either in the same day, immediately after ERCP, or next morning, or to wait for after 7 days and operate the patient.
If the patient has pancreatitis, it is recommended that early cholecystectomy to be done within the same admission so that it will not recur.
Yeah, true, true. And I brought this photo for stones, multiple stones of different sizes. Some of them are small stones. If you are going to wait for a longer time, probably another stone will pass. Patients with common bile duct stones, most likely they have a wide cystic duct. So we are going to remove stones, and then some stones will come down to the common bile duct. We better operate as early as possible. But for the surgeon, for surgery to be easy, either on the same day or next morning, or let 7 days pass and then operate. In pancreatitis, if there is persistent obstruction, then we request ERCP. Otherwise, we do not request ERCP. We just do MRCP to make sure that the common bile duct, the stone has passed, no stone. And the picture in here, it shows a distended ampulla with an impacted stone in a jaundice patient. Now, this is an MRCP, and it showed multiple filling defects within the common bile duct. And now we know the timing of surgery after ERCP. Nobody would like to operate when the patient has got ascending cholangitis because of the manipulations of ERCP, or there is pancreatitis because of manipulations of the ERCP itself. So the answer is always we judge the patient. The best sentence written in the textbook of surgery by Bile and Love is every case should be taken on its own merits. Every case should be taken on its own merits. And the decision should be taken for each patient. The decision could be different from the other patients. Now, when we operate, are we going to do on-table cholangiogram? Whether we are doing open cholecystectomy or laparoscopic cholecystectomy. Are we going to do perioperative cholangiogram or not? Both answers are correct, but the best is to defend the answer. Either we do it and you defend why we do it, or we don't do it and you defend why not to do it. Can anybody give it a trial to answer? Today is the day to defend your answers. It is not a defensive medicine. It is not a defensive medicine. You are going to shoot the patients for other surgeons. You don't want to operate at all. No, we want to operate, but we want to show an evidence why we are doing this and why we are doing that, why we are not doing this, why we are not doing that. It is not a defensive medicine. We are not referring patients to other people to operate, and we do not like just to say, to stay without surgery, no. And it is still.
Yes, hello, Prof.
Yes, sir.
Yes, actually I don't do a routine cholangiogram unless the patient's having high liver function test with the possibility of basostones with the MRCP. The reason why I'm defending now my critique, the rationale after this is that intraoperative cholangiogram doesn't actually reducing the risk of the injury, and on the same times, it's not really, if there is a small stones that's not giving us symptoms, there is a chance of 60% to pass away without any need for any kind of intervention.
Correct, correct. If there is a small stone, it might pass, and a second MRCP after a week or two can remove it.
Yes.
So if you do not want to do an on-table cholangiogram, if you don't want to do a perioperative cholangiogram, well and good. The thing is you defend yourself. You go and do just simple cholecystectomy, laparoscopic, or by open cholecystectomy, and no need to do on-table cholangiogram. However, if you want to do an on-table cholangiogram, probably you want to perfect your work. Mr. Ahmed Nassar last time, Professor Ahmed Nassar was saying that he explores the patients directly without ERCP, without MRCP. So this is very judicial. If you have the facilities to do it, you go and do it. But now the description, the question is, I want somebody to describe for me how he does in an open cholecystectomy perioperative cholangiogram. Can somebody just explain to me how he can do it? On-table cholangiogram is not without complications, is not without advantages and disadvantages. The only thing I want you in each and every fact to know what are the things around that fact. And you choose what suits your situation. How do in open cholecystectomy, how do we do an on-table cholangiogram? As a prerequisite, of course, we should have either a CR or portable X-ray machine. And the table itself should be suitable to put an X-ray film behind the patient. And the patient should be in a position head down 15 degrees, 15 to 20 degrees, and tilted to the right side 15 to 20 degrees through the line of the common bile duct just lateral to the vertebral column. The contrast should not come over the vertebral bodies. Bones are white and the contrast is white. So it is very difficult to make diagnosis. You just throw the length of the common bile duct just lateral to the vertebral column by putting the head down 15 to 20 degrees and putting the right side down 15 to 20 degrees. Then you ligate the cystic duct near the Hartmann pouch, near the neck of the gallbladder. And you make a small nip, a small opening in the common bile duct, and you introduce a catheter. This catheter should be connected to a syringe containing normal saline, and then the syringe should be containing the contrast. The most important point is that neither the syringe or the catheter should contain any air bubble, because air bubble will be seen as a stone. So the theater attendant should prepare the syringe and the catheter without any air bubble. You go in, you hold it with a stitch in the cystic duct, and you inject something about 2.5 milliliters of contrast or 3 milliliters just to delineate without descending the common bile duct and to see if there is any intrahepatic biliary dilatation. You see, you comment on 3 things: intra and extrahepatic biliary dilatation, presence of filling defects, and contrast should pass freely to the duodenum. If there is dilatation, means there is evidence of obstruction, previous or now. And if there are filling defects, most likely these are either bubbles from your irrigation system or these are stones. And if the syringe and catheter are without air bubbles, most likely these are stones. And the contrast, if it didn't pass down either into the duodenum, this means that there is a spasm in the ampulla of water or a small stone impacted at the distal end of the ampulla of water, if it is not a tumor. Having done that, then you make another film, you inject something like 5 to 6 or 7 milliliters of a contrast to make sure that the contrast has reached the duodenum. I said this because every registrar should have seen it and should be capable to do it in hospital later. And of course, some surgeons, most of the senior surgeons, they can do perioperative cholangiogram during laparoscopic surgery. It is not a problem. On-table cholangiogram is an excellent investigation. It has an accuracy of detecting common bile ducts almost in 98%. And making a correct diagnosis that there are no common bile duct stones, 100%. So it is a superior most investigation for the stones in the common bile duct. However, if you are from the proponents to say, I will not do it, you are correct, but you defend yourself. And ERCP will be ready if there is any missed stone to be removed. Or if you are from the proponents to do it, you do it, and nobody will say you are wrong. As I said, the sensitivity of perioperative cholangiogram to detect common bile duct stones is 98%. A specificity to say no, there is no stones in the common bile duct, 100%. However, it is routine use. As my colleague said clearly, he will not do it routinely. It increases the operative time and it increases the cost of surgery, and increasing the operative time is not without chances for morbidities and probably mortalities. Now, we have mentioned before, the previous admission could have been pancreatitis. And from this study, from the Society of Surgeons, Surgeons for Laparoscopy and Endoscopic Surgeons, Society of American Gastrointestinal and Endoscopic Surgeons, the pancreatitis might be the first presentation. In the first presentation, usually biliary colic, it could be cholecystitis, it could be pain, anything. but sometimes in about 10% to quarter of the patients, 25%, it could be the first presentation, acute pancreatitis. And we know the degrees of severity of pancreatitis and the seriousness of pancreatitis. And I think all registrars, they know the criteria, the Ranson's criteria or Glasgow criteria for severity of acute pancreatitis. This should be at the tip of their fingers. We know, we confirm the diagnosis by lipase and by amylase. And we said before, in pancreatitis, we only operate cholecystectomy when the acute inflammation has subsided. We don't go for emergency surgery. And we don't go for ERCP unless there is persistent obstruction. Now, after all this discussion, we would like to know after this scenario, what are we going to do for this patient? I think the answer is clear. He has to go for ERCP and to go for MRCP, then ERCP to clear the stones. When his condition settles, then he should have an early surgery for operation to make sure that there is no edema to obscure the view for us. Now, I would like just to talk about the situation in Sudan, and probably most of you know it. Some of you who would like to go for prayer in the coming 5 minutes, or to drink a cup of tea or juice, they can do. Anyhow, most of you are at rest at home. Please feel free. But now let us see what is the situation in Sudan. When I came to this back home in 1995, the hospitals doing open cholecystectomy in 1995, there was no laparoscopic surgery. I came in January. In January, there was no laparoscopic surgery in Sudan. It has started in the 24th of April in 1995, in April. So it was only done in the 3 towns in the capital, Khartoum, North and Omdurman. And it is done in Adbara, Port Sudan, Gadarif, Madani, Al-Ubaid, and Al-Fashir. And Juba by the surgeons who go from the military hospital at that time in 1995. This was for open cholecystectomy. And then in 2016, a lot of hospitals are doing open as well as laparoscopic surgery. 1995, this is the year when the board, the Sudanese board, the Sudanese Medical Specialization Board was inaugurated. It was in 1995. And now you see the effect of the Sudanese Medical Specialization Board. In Karima, in Dungula, Port Sudan, Ad-Damer, Adbara, Shandi, حلفة جديدة, كسلة, كوستي, سنجا, النهود, الفولة, نيالا, الجنينة, and so on and so forth. And I will be waiting also for my colleagues to tell us what is happening in 2020. I think this question will be for you and somebody should work on it. I think we should feel optimistic. We are going forward. It is a good evidence that we are progressing. But this progress, I feel it is mainly personal-based initiative, because I feel, and I bitterly feel this, a lot of my colleagues, they went to India, and some of them are now in South Africa, getting specialized on their own, a money that they need for their future families. They should have got their specialization here. Anyhow, they train themselves in laparoscopy, and it was just a personal-based initiative from themselves. And also, they have pressed on their hospitals, whether they were governmental or they were private hospitals, to bring the laparoscopes, and they went on doing things, and we went ahead. And I think in 2020, the number of hospitals doing laparoscopic surgery and doing open cholecystectomy should be far more than this. I want just to speak in this rest period for the others to speak about some of my experience, and of course with others. We work usually as a team. This is the professional attitude. Our first experience in laparoscopic cholecystectomy, as I said, we started in the 24th of April 1995. And I am very grateful to Mr. Ahmed Tahir, who told me, go ahead and operate. And if anybody, I was under assessment at that time. And it was very clear that nobody under assessment should operate in the private sector. He told me, go and operate. And if anybody says to you anything, just come and tell me. And he himself and the great people, Mr. Sanhouri, Professor Sanhouri, and late Mr. Kailani, alayhi rahmatullah, they came and they attended the operation, the laparoscopic cholecystectomy I was doing at that time. In fact, late Mr. Kailani, he assisted in holding the camera for me. I will never forget this at all for them, because this was the base where laparoscopy started to flourish. We felt the confidence from them, and it started to flourish after that. After in fact, it was started by late Professor Isam al-Ijel, alayhi rahmatullah, and myself. We have done few cases. In 2 weeks' time, he left back to the Gulf countries, and I continued operating. And after that, in a very short time, laparoscopic cholecystectomy started in the military hospital in Omdurman and in Al Jazeera in Madani Hospital. And both groups, they have started with the aid of a group of surgeons coming from Saudi Arabia. But for us here in Sudan Clinic, it is a private small clinic in front of Khartoum Hospital. We started Professor Isam Ijel and myself. And then I continued after that doing the job. So the first experience for the cases I have done was published in the Saudi gastroenterology in 2001. And at that time, I was working also at Ibn Sina, and Professor Abdulmajid Masa'ad was fond of doing a mini incision open cholecystectomy. And then we made a prospective comparison between laparoscopic and mini incision cholecystectomy. And in 2000, we published a paper in the Kuwaiti Medical Journal. I think both of them, you will find the abstract in the PubMed. This was a paper in the Saudi gastroenterology. The experience at that time was about 201 cases of laparoscopic cholecystectomy. And anyhow, a second paper in the Saudi gastroenterology itself we have published also. It was on intracorporeal vicarial ligatures of the cystic duct. In fact, at that time, clips were not provided regularly, and sometimes we find difficulties in getting clips. And I used to use intracorporeal. Also, when the cystic duct is wide and cannot be controlled by the clip, I go ahead and do an intracorporeal vicarial ligature. And I made a small study of 64 patients divided into 30 patients I did with clips and 32 patients with ligatures, and all they have done fine, no complication at all. It was published in the Saudi gastroenterology in 2002. And that was 19 years back. And then I had quite a good number of cases who were discharged 10 hours after operation in the same day. In fact, when I reached the number of 602, I had about 136 patients discharged 10 hours after surgery. I operate them at about 8 o'clock in the morning, and 5 to 6 o'clock in the evening when I come to my clinic, I discharge them home. And I followed them, and no problem happened. And it was published also in the Sudan Journal of Medical Sciences. I think it is one of the best journals now in Sudan. It is being regularly issued 4 times a year, or 3 times a year, every 4 months. And now we have a publisher outside the country, and we are working hard to enter the Scopus in fact, there is a small study also we have done together with my colleague, Mr. Ahmed Mohammed Adam Saeed, who is now the Dean Faculty of Medicine at Omdurman Islamic Hospital. And this, when he was working, he did quite a few number of pediatric cases, cholecystectomies. And at that time, I thought he would be become a pediatric surgeon, but he went on to become a general surgeon with laparoscopic interest, and he's doing a lot of laparoscopic surgery now in Omdurman Hospital. Now let us speak about outcomes. Probably those who went to prayer, they came back. About outcomes, let us speak from a study in Belgium. This study was, it is a number of patients operated by 53 surgeons. The total number of patients was 1,089, and all of them are acute cholecystitis. Usually people, they give a lot of weight for acute pancreatitis, acute cholecystitis because of the fear of injury. But in simple gallstone disease without inflammation, also injuries can occur. Anyhow, these 1,089 patients, the vast majority were done by laparoscopy, that is 93%. However, they went directly for open cholecystectomy. About 7% of them, they went directly for open cholecystectomy. So the message is that we should not feel embarrassed if we go for open cholecystectomy. In fact, in my training, the person who was training me and others, he said, if your conversion rate is less than 10%, you are doing harm to the patients. So if you feel any problem, you go ahead and convert. This is our message here. Probably it does not apply to other advanced countries. But for beginners, they should have a very low yield to convert. And for this group of surgeons, 53 surgeons, they have conversion rate of 11.4%. And most of these patients converted were males. In fact, the males converted from laparoscopic to cholecystectomy are double the number of females. So we should put this point in mind, and we are going to come back to it. And they have complications in 5.5% of patients, with the incidence of biliary injury of 1.2%, which is an international figure, 1.2%. Now let us fragment this number. The total number, as I said, it is 1,089 patients. Those which were done by laparoscopy were 899. That is 82.5%, and some were converted. Because some were converted, the total number of conversion were 166, that is 11.4%. 116. And those who went ahead for open cholecystectomy were 74 patients. And now let us look at the patients who had successful laparoscopic cholecystectomy. They had 4 bile duct injuries, 13 leaks, a total of 17 biliary complications. Those who had conversions, even they have worse results. They have 7 injuries. In fact, if it was not difficult, they wouldn't have converted. They have 7 injuries, and they have 9 biliary fistula, fistulae, and they have a total of 16 biliary complications. At the same time, for the 74 patients who went ahead for open cholecystectomy from the start, there were 2 common bile duct injuries and 3 biliary fistulae, a total of 5 biliary complications. So it can happen in best of hands. Now, if we go back to this slide, we said the conversion rate is double in males. And before I said, as we advance in age, complications arise. Then they look into the predictors for conversion. And they found that males who are more than 65 are having higher rate of conversion. And we have to put in our mind that any male who is more than 75, more than 65 years of age, we have to put in our mind that he might get converted to open cholecystectomy, and we might need help during his surgery. And also patients who had got previous attacks of cholecystitis and previous attacks of biliary colic, they might, it is a good predictor for conversion. Operating patients with post-bilharzia fibrosis, I will come to this later. We have published in Ibn Hospital, I think it is the center where the vast majority of common bile duct injuries that occur in Sudan were corrected and operated in Ibn Hospital. And we did a review of these cases and we published it in the Sudan Medical Journal in the year 2007. Now, my 7th message. I hope people will remember the previous messages. Anyhow, my 7th message is that the signs of bile duct injury, we operate the patient laparoscopically and we discharge them tomorrow. And we do open cholecystectomy and we discharge them next day or the day after. But look at this. If the patient is failing to recover quickly, if the patient has fever with or without rigors, if he develops nausea with or without vomiting, if he has abdominal pain, all this after surgery, with or without dissension, just think of biliary complications. Very simple symptoms, not recovering quickly, fever, nausea, abdominal pain. Just re-investigate the patient to detect early problems. Definitely, if he has jaundice or bile leak, definitely has a problem. MRCP and refer him to a surgeon who is competent to do reconstruction. Now, 2 questions, not from me. It is from the surgeons, Society of American Surgeons of Gastrointestinal and Endoscopic Surgery. Which of the following is associated with an increased risk for conversion to open cholecystectomy? Just best of 4. Which is the best answer? Is it the male sex, or history of gallstone pancreatitis, or obese patients with body mass index more than 35, or previous upper or lower abdominal incisions? Which is the most likely of this to be associated with the increased risk for conversion? Can anybody attempt the answer?
Male 6.
Male 6. Male 6. Male 6 above 65 is more prone to develop, to have conversion. In fact, midline incisions, upper or lower midline incisions, you can go with the Hassoun method with a direct vision, insert the very first port, and then you can proceed. You can do adhesive lysis, remove the adhesions, and proceed with surgery. Previously, in the early days of laparoscopy, it was contraindicated, but once the Hassoun method was developed, it was not anymore contraindicated. Again, this is another question from the same society. Reverse sulcus. Do you know what is reverse sulcus? Some people are fond of names. Reverse sulcus is the sulcus where the right hepatic duct comes from. The right hepatic duct lies in a fissure, and that fissure is the reverse sulcus. So the reverse sulcus, this fissure where the right duct lies, it is in the same anatomical plane of which of the following? Is it of the gallbladder, cystic duct, or common bile duct, or duodenum? This is an excellent landmark to avoid injuries.
The cystic duct. I think the
Cystic duct. Can anyone have another chance?
The gallbladder.
Common bile duct.
Any
Common bile. The gallbladder.
It is the same line, horizontal line of the common bile duct. Always we should keep our dissection anterior to that fissure, anterior to the reverse sulcus. We'll see it now. This is a gallbladder. Here is the cystic duct. This is a fissure where lies the right hepatic duct, and here is the continuity in the same plane, the common bile duct. The dissection should always be anterior, it should be more, and then we retract with the grasper of the Hartmann pouch, we lift the common bile duct here. The cystic duct will reach up to this level when we retract it up. This is an excellent landmark. Never dissect at the same level and never ever posterior to that level. You will be dissecting the common bile duct. It is an excellent landmark. The reverse sulcus, or the fissure or sulcus where the right hepatic duct lies. It is seen in 80% of patients. It is seen in 80% of patients. If the anatomy is beautiful and the case is easy, you can dissect the artery. And in fact, I am fond of this. I'm fond of dissecting the cystic artery. This is the cystic artery. This is the artery of the cystic duct. And this is the cystic artery that goes to the gallbladder. The gallbladder is the cystic. This is the cystic artery. This is the artery of the cystic duct. This area is very important. The callus triangle, where a lymph node lies, the lymph node of Lund, and the cystic artery, and we should clear the gallbladder at its bed. The right hepatic duct is lying here at this area, very much near the lower part of the body of the gallbladder, and it is liable to injury. So we should trace it, and in fact, those who assisted me, and I have assisted them in their surgeries, we go on dissecting the artery till the middle part of the body of the gallbladder, and we will see it in a minute. I hope this film will work. This lady has got multiple small gallstones. This is why I kept milking the cystic duct. I didn't want during manipulation any of the small stones to go into the common bile duct. Although the cystic duct is not dilated, but I keep milking it up towards the gallbladder, and we see the artery here. And let us just go a little bit. This is the artery, and probably also we dissected, we started clipping it. And sometimes when the structures are not dilated, I apply one clip to all. One clip to each and one clip to all. And the clip should be very much near the neck of the gallbladder. We should keep far away from the common bile duct. We should always keep far away from the common bile duct. This is the clip on the artery. And this is the artery, very clear, going to the gallbladder. It is not a duct. And we will see in a minute. You see, we are going towards the body of the gallbladder, so it is not a duct at all. And we have lifted the gallbladder from the area of the right hepatic duct, from the hilum of the liver. And usually, at the distal end of the artery, I do not lose a clip. I just coagulate it. That is all. That is all. And now let us move forward. In acute cholecystitis, the operative approach. In fact, sometimes in acute, the situation is very difficult. If the situation is very difficult, please ask for help. And this was mentioned by Professor Ahmed Nassar. Ask for help for a surgeon or for a senior registrar to give you. Don't spare a pair of good hands. Always ask for a pair of good hands to help you. And if you find difficulties and you would like just to stop, just put a drain and come out and refer a patient to another person. Or from the start, you select your patients, particularly when you are started doing laparoscopic cholecystectomy. Select cases and be very careful. In fact, I have a saying, I used to say it to my colleagues in Ibn Sina Hospital, and I think this will be probably the only sentence I will say it in Arabic today. الماء بخاف ما راجل. الماء بخاف ما راجل. مش اللي بخاف ما راجل. لازم نخاف. We should be afraid of the patient, we should be afraid of the pathology, we should be afraid of the law, and we should be afraid of God. Surgeons are brave. They are doing a lot of difficult surgeries. They are working hard to save lives, but we should respect tissues and we should respect human beings. So if we cannot complete safely cholecystectomy, go and convert. We have seen now, even in Belgium, they have went ahead for more than 70 cases, 76 patients for open cholecystectomy directly, without any attempt for laparoscopic cholecystectomy. Go ahead for open cholecystectomy. If you have difficulty, the first thing to do, increase your incision to have better view. Don't operate with small incisions for the sake of beauty and you make some injuries. Increase small incisions, they heal in the same time of the big incisions. Extend your wound, ask for a competent person to help you. Probably you need 2 persons to help in open cholecystectomy, and go slowly. Respect tissues. Start fundus first. Open the gallbladder, remove stones, put a catheter in the cystic duct. You can inject contrast or not inject contrast, but make sure that there are no further stones in the cystic duct. You can do a subtotal cholecystectomy. Use suture near the neck of the gallbladder to avoid touching the right hepatic duct and the common bile duct. Safety comes first. Safety comes first. So we have to work like this. Those who are doing laparoscopic cholecystectomy, I wonder how they do subtotal cholecystectomy, because the area is too wide to be taken by a clip, unless they are capable of suturing at the neck of the gallbladder. Then they can do subtotal cholecystectomy. If you didn't find any help at all, be cool. Just put a drain and come out and refer the patient, or call another patient as a second time and explain very well to the patient and go for surgery in a second session, or refer the patient and explain to him to another surgery. In fact, during the early days of operating in the biliary surgery, just keep an eye on white blood cell count. If it is more than 18,000, the surgery most likely will be difficult. If it is more than 18,000. And if the time of acute cholecystitis is a little bit more than 3 days, it will be difficult dissection. Wait till it subsides. Treat conservatively till the condition subsides. If the gallbladder is palpable, treat conservatively, unless it is a mucocele with impacted stone. Or ask for help, plan things and ask for help. Particularly in the old sick patients with comorbid diseases, ask for help or refer the patient. Better than to have litigations and go to the court and blames and this and that and gossips and a lot of talk and nightmares and you cannot sleep. Now, the international rate of bile duct injuries in the early days of laparoscopic cholecystectomy, it was high. But I think currently it is in the range of 0.2 to 0.5%. Also in our country here, I think it is almost the same thing. And it improves with the learning curve. However, whatever experience one develops, one is not immune from injuring the common bile duct. Whatever experience we have, we are prone to develop. People explain this when injuries occurs in expert hands that it is a sort of visual malperception. The competent surgeon can swear that I have done things right, I have seen the common bile duct, I have ligated the cystic duct. When he reviews the film, then the recorded film, then he will see where he injures the common bile duct. It is a visual malperception. And what is beautiful about laparoscopy is that all the theater and the theater attendants and your colleagues assisting you will tell you, no, you are proximal to the common bile duct. Not like the open cholecystectomy. Not all people are seeing the view inside the hole of open cholecystectomy. Injuring biliary ducts can be repaired, but vascular injuries is a disaster. And the common injured vessel is the right hepatic artery. If it happened, a lot of bleeding will occur. Just grasp it by anything and convert open. And if you are doing open surgery, press, suck, call for help, and clip it, unligate it. Very difficult to repair, and even it is nearly impossible, I will say, to repair the right hepatic artery. Ligate it. Although the consequences that the right lobe of the liver might develop some sort of ischemia because the portal vein carries oxygen with the cell. In fact, the majority of blood is taken to the liver by the portal system. So ligate the right hepatic artery. Otherwise, it will cause a very bad gush of blood. It will disturb your moods like this. Just ligate it. But make sure during ligating it not to ligate the right hepatic duct. If the right hepatic duct is injured, the repair is difficult. It might need an expert hands to do RONY and hepaticojejunostomy. Of course, injury to the common hepatic artery and to the portal vein are extremely rare, and if they happen, they are nearly fatal. And this is class 1 injury. It is just nipping part of the common bile duct. It can be repaired over a T-tube. And this is a class 4 injury. When there is clipping or ligation of the right hepatic artery and right hepatic duct. The left duct is open, it is patent, it is class 4. But it will be more severe and bad, and they will classify it as E when there is vascular injury as well, or when there is complete transection. Very bad injury. And sometimes I think people have seen these images with multiple clips, means it was difficult surgery, and probably one of the clip is going to clip the common bile duct or common hepatic duct itself. Now back to the situation of common bile duct injuries in Sudan. In fact, this is a little bit old study. I hope my colleagues also will tell us the situation now. From 1998 to 2005, that is in 2 years' time, we had about 53 patients with biliary injuries, and most of them are high injuries in the hilum of the liver. And in 3 years' time, from 2010 to 2013, 3 years' time, we had 40 injuries. And in the other subsequent 3 years, we had 61 injuries. And that was a total of 150 cases of common bile duct injury. These studies were done by late Dr. Nuha alayha rahmatullah. When we remember Hariel, we feel very sad. I hope by now her soul will be in paradise. And Dr. Ala Musa and Dr. Sawzan Abul Qasim, who is now a surgeon at Ibn Sina Hospital. I think also she is doing now repair for a lot of common bile duct injuries, repeal surgery, and these things. Now, we did some analysis 2013 to 2015 for the operations. This analysis showed that in 2013, 14 cases, they underwent reconstruction, and 6, they had drainage of bile, just drain, and 3 died of them pre-operatively before any surgery. They came in severe sepsis, and 1 he has post-operative mortality. In the year 2014, 8 patients underwent reconstruction, and 8 of them had drainage for bile leaks, and 3 had pre-operative mortality. You see, the message here is that don't refer patients very late. If you feel that you have injured the biliary ducts, either you call a competent person to construct it immediately, and if an early repair of the biliary system will have a good chance for repair, and the success rate will be something like 93%. If you did not find any person to help you to repair it for you, then you refer the patient to be operated as early as possible by somebody who is expert in repairing these injuries. But if you kept the patient and being reluctant to refer it, and the patient develops sepsis, renal impairment, abdominal collections, this and that, the chances of dying before reconstruction is high, and still there is a chance to die after surgery, after reconstruction. So please don't hesitate if something happened to go and operate immediately. And then some analysis for these complex types of injuries was done. And the message is that what we feel till 5 years back, that the injury was rising, and our questions for our colleagues at Ibn Sina Hospital and other hospitals, do you see a lot of injuries, or the experience is well developed now in open as well as laparoscopic surgery? In fact, most of the injuries I have spoken about were in open cholecystectomy. Very few, very rare injuries in laparoscopic surgery at the time when we did this study. And now we want to see what is the status now, and the answer should be from our colleagues operating in governmental hospitals. Because these patients, they stay in hospital for quite a time, not less than 10 days, probably 3, 4, 5 days before surgery, and the same period after surgery, like this. So also here, I would like work in a team. This is professionalism. Work in a team. Help each other. Either you will be called to help, or you will call, don't feel embarrassed to call somebody to help. And because of this unforeseen problem, the visual perception, any of us is liable to cause an injury. And again, another call that surgical GIT specialization should be started in Sudan as soon as possible, for the sake of patients and for the sake of the progress of surgery and specialty, and for the sake of safety of our colleagues. Mind you, a lot of cases we have seen common bile injury in young females. These young females, they never live their normal lifespan, and their quality of life will be very poor. Now the question, is this the whole story? Are there any other unseen bile duct injuries? Let us see. We went to Fidel Hospital, where a lot of ERCP is being done. Now I know in other centers, Al-Atibba and other areas, they are doing ERCP. And in the period from March 2003 to 2013, about 1,830 ERCPs were done in Fidel Hospital. And now there are 4 consultants, I think probably more, doing ERCPs. And the post-cholecystectomy were only 102. In fact, ERCP is sent for patients with head of pancreas to put a stent to drain the biliary system, or cholangiocarcinoma to put a stent, high skin tumor to put a stent, and a stone before surgery to be removed, or missed stone after surgery to be removed. So post-cholecystectomy referrals were only 102 cases. And CBD stent for post-cholecystectomy bile leak was done in 13 patients. Post-cholecystectomy stricture was dilated and stented in 22 patients. Mind you, bile around the common bile duct might induce tough fibrosis and cause stricture by itself. Any injury might heal by fibrosis and cause stricture by itself. And a retrieval of missed stone and with or without putting a stent was done in 38 patients. Complete ligation or clipping of the common bile duct was found in 26 patients. This should have been diagnosed by MRCP, not by ERCP. Because the surgeon is interested in the upper part of the biliary system, not in the lower part of the biliary system. Biliary injuries should be diagnosed by MRCP, not by ERCP. And in 3 patients, they found post-surgical, post-surgery, there was a periambulary tumor, and in one case, sclerosing cholangitis. Now, remember that in a period from 1998 to 2015, 154 reconstructions were done at Medicine Hospital. And from 2003 to 2013, ERCP, post-cholecystectomy, bile leak, stricture, missed CBD stones were 102 cases, and making a total of 256 cases. Now, what is the current situation in Sudan? I think the answer will be by our colleagues. I think we are coming towards the end of my talk. My message at this stage, we should establish a national cholecystectomy registry. I'm calling for my colleagues who are operating now, please, all young surgeons have got very nice and very beautiful relationships between each other. Try to make a national cholecystectomy registry. I think this is just a review for what I have said before. This is an injury for common bile duct which was repaired over a T-tube. There are some special pathologies. I will just show you for those who haven't seen these things in a few minutes. Gallstones with cirrhosis. At the beginning of laparoscopic surgery, cirrhosis was classified as a clear contraindication, like any other conditions with bleeding diathesis. So, but with time, people were able to do, particularly patients who are grade 1 and 2 or child A and B can be operated laparoscopically or even with open surgery. And in fact, we had a paper also in these in patients, I think 37 patients with periportal fibrosis, child A and B. Because cirrhosis was thought to be a cause of high mortality and morbidity, because of cirrhosis itself, it can cause bleeding, postoperative hepatic failure, sepsis, and multi-organ failure. But we know the difference between cirrhosis and periportal fibrosis. Fortunately, in periportal fibrosis, usually liver functions are not deranged like in cirrhosis. But we have to put in mind, in periportal fibrosis, the bilharzia induces a lot of fibrosis inside the liver and in the biliary system, particularly in the gallbladder. Usually the gallbladder is very thick. And some people who are doing ultrasound will say this is a chronic cholecystitis. The word chronic cholecystitis has been eliminated from literature. There is nothing called chronic cholecystitis. Chronic acalcular cholecystitis, nothing called chronic. It is acute calcular, acute acalcular, and chronic calcular. There is nothing called chronic acalcular. So periportal fibrosis can be seen in ultrasound like a thick, very thick gallbladder, and it can also cause cirrhosis, or periportal fibrosis can cause dull aching pain in the right hypochondrium. So we should have some sort of clinical competence to differentiate, is this due to pain due to gallbladder, or is it due to the cirrhosis and enlarged liver, stretching the capsule of the liver itself? In fact, we have a few patients, something like 37 patients, published in the Journal of the Society of Laparoscopic Surgeons. It is an American journal in the USA, a famous journal. Late Professor Assam Al-Ajel, myself, and Professor Suleiman Saleh Fadel, we published this paper on periportal fibrosis. At that time, we had grade 1 as a grading of fibrosis by ultrasound, grade 1, 6 patients, grade 2, 7 patients, grade 3, 5 patients, grade 4, 7 patients. And by endoscopy, esophageal varices, grade 1 were 10 patients, and grade 2, 10 patients, and grade 3, 5 patients. You should very well prepare these patients before surgery. Now, the results, the operative time was ranging from 30 minutes to 2 hours, with a mean of 75 minutes, and the average blood loss something like 50, reaching up to 18 milliliters as estimated. And we have converted 2 patients to open cholecystectomy, and 23 patients, they have stayed in hospital each for 2 days. And the average time to return to work was about 2 weeks. No mortality. In ultrasound, this ultrasound by an excellent radiologist, and he mentions clearly that the gallbladder is dilated with thickening of the wall and edema and thick bile content. It is compatible, he said, with cholecystitis, probably acute on chronic, no stones. We say, no, this is not cholecystitis. Treat conservatively. If he mentioned anything about the liver, then just treat. If he said there is any nodularity, he said here, spleen is enlarged and coarse. So we should take care in these patients very much. The gallbladder usually, as I said, it is very thick. Another category I would like to speak about is gallbladder polyps. We see it from time to time. If the polyp is around about ½ centimeter or bigger, you remove the gallbladder. ½ centimeter or bigger, you remove the gallbladder. They cause symptoms, they cause pain. If they are minute stones, minute polyps, then you treat conservatively. You treat conservatively. Probably they are just cholesterolosis. Another category, the third category, is that the gallbladder could be sitting deep in a fissure in the liver, like this. However, the dissection is not difficult. And this is the reverse sulcus, if you remember. And this is a wide cystic duct. It should be dissected easily. And we should make sure that no stones has passed in the common bile duct. If you dissect it like this, probably it is going through the liver. Usually it is deep in the fissure in the liver. Another category, patients who are having wide cystic duct, they have a chance for stones to pass through the common bile duct, and sometimes the clip might not go across. These are the patients you need to tie them with endocorporeal or extracorporeal ligatures. You have to master one of these 2 R's to handle the wide cystic duct. And the fifth case is the Merisi, a big stone impacted in the neck of the gallbladder or in a wide cystic duct and probably protruding into the common bile duct or pressing the common bile duct from outside. We know Merisi type 1, 2, and 3. Then at these cases, you have to open the gallbladder, remove the stone. You remove the stone, you can remove it in an endo bag if you have endobag. If you do not have an endobag, then you remove it in a glove finger. You cut the glove finger, put it inside, put the stone inside it, and you take it out. And then you have to suture the knee at the neck of the gallbladder after removing the gallbladder. But you should be very careful and very conscious not to injure the right hepatic duct or the combined duct itself. This is the big stone. And now one more category, and that is when you find a double duct sign like this, very much dilated combined duct and pancreatic duct, tortuous and dilated, and small stones inside the gallbladder. Most likely the cause is carcinoma head of pancreas. Don't take the gallbladder. Most likely the cause, just do tumor markers, do all investigations for head of pancreas, most likely. Because we have seen patients who has undergone cholecystectomy and the patients develop in few months very big tumor in the head of pancreas. Dubin-Johnson syndrome, this is one of the problems of synthesis of bilirubin itself. Anyhow, in this you find a black liver. I would love to show you really a black liver. Black like, open, it doesn't like to open, although I just opened it before.
اطلع من الفول سكرين واعمل كليك عليه وهو بيفتح.
Yes, yes, you are right, you are right. You are right. No. You are right. Right. And this is it. Look at this. Okay. And there. Yes, it is going to open now. It's a Dubin-Johnson syndrome. I know this patient, and till now we have a good relationship. He and his family, they have the same thing. He presented with jaundice and gallstones, and we have taken a liver biopsy, and it has been seen by Professor Ahmed Hassan. And this is the black liver. You see the surface of the diaphragm, normal color, and this is the black liver.
Share the screen, please, Professor.
Pardon?
Share your screen. Your screen is not shared.
Is it clear now?
Yes, yes.
Yeah. Black liver. Black liver. The dissection was not difficult. Cholecystectomy was not difficult. But this is the first case I have seen. Also, you can see dark liver, I will say just dark liver in chronic jaundice. In long-standing jaundice, you see a dark liver. But such black liver like this, it is a long-standing congenital jaundice, congenital reasons for jaundice like Dubin-Johnson syndrome. I think we can go forward. We can go forward for the next. وفيلم خلاص ذاته انتهى. In this slide, you will see a lot of adhesions between the liver and the surface of the diaphragm. And these are Creuss-Fitzhugh syndrome, most likely due to chlamydia. And these patients, you better give them azithromycin. You better give them azithromycin when there is massive adhesions. Also, one more film I would like to show you. These are beautiful films to come out from the screen itself. This one, this is a very hard. احنا طالعين برا من طلعنا من السكرين، ما طلعنا من الفول سكرين. نطلع من الفول سكرين هنا. ايوه، وبعدين بيفتح معانا، بيفتح معانا. ايوه، ده البريفيوس وان. ده نقفله كان الفيلم. دي كلها جونسون. نحن ما طلعنا من الفول سكرين، ما طلعنا كده، طلعنا من الفول. ايوه دي البورسلين. دقيقه، دي البورسلين. نشوف كده. لكن ما فول سكرين، لكن احنا نرجع. ايوه هي بيفتح، انا متاكد بيفتح. ايوه فتح. See this gallbladder. This gallbladder. It is very hard. It is stony white and it is stony hard.
Share the screen, please. Share the screen, please.
هنا.
Yes.
I was sitting on it. Anyhow, we are going to move forward. And then the outcome of perineal injury depends on the time of surgery. Early referral will have very good outcome with a success rate of 93%, and delayed referral will have a very low success rate of 17%. So if you are caring for your patient, if you want to not to go for litigations and problems with patients, refer as early as possible. Also, the outcome depends on the level of injury. The higher level, the worst the outcome. And also the control of sepsis. If you refer the patient early without sepsis, outcome will be good. If you refer late with sepsis and hypertension and renal problem, then outcome is gloomy. Experience of the operating surgeon. So anyone who has not done his first repair of common bile duct should request a competent surgeon to help him, or should refer the patient to a competent surgeon and go and help the competent surgeon in his hospital. Screen ما ظهرت. Share screen. طيب. The worst thing also if you have vascular injury. In open cholecystectomy or in laparoscopic cholecystectomy, people will panic. My advice is that try by a grasper in laparoscopic cholecystectomy, hold the bleeding site and wait for not less than 6 minutes and let somebody else count for you the 6 minutes. Don't count it yourself. At least 6 minutes, and probably better to go for 12 minutes. Just by a grasper, hold the bleeding site. It will stop by itself. It is a natural process made by God. Vascular spasm plug of platelets, and mesh of fibrin, it will stop by itself. Just keep holding it between 6 minutes to 12 minutes, but somebody else should count for you the minutes. The worst thing is the vascular injury. If you panic, you are going to injure the bile ducts. This is the message. And we know there are a lot of classification by Bismuth, Stewart, and Way classification, a lot of classifications. Now we come to the end with recommendations. For the consequences of the bile duct injuries, significant impact, injuries have significant impact on the quality of life. And they reduce the overall survival of patients. And they lead to frequent medico-legal liabilities. So, for precautions, you look for symptoms, for symptomatic gallstones. Asymptomatic gallstones better not to be touched, unless you have got good reasons. A patient with asymptomatic gallstones who is living in a remote area, probably he should have a chance to be removed. With a person who has good experience. But if patients have asymptomatic stones, better not to touch them. And even symptomatic patients in the COVID era should be treated conservatively. Even symptomatic gallstones should be treated conservatively in the COVID era. Now, try during investigations, ultrasound and other investigations, avoid thick-walled gallbladder that does not contain stones. Most likely, either it is due to bilharziasis or it is due to pancreatic pathology or something like this. Anyhow, and properly diagnose causes of dyspepsia. Pancreatic tumors can cause also dyspepsia. Not any distended gallbladder containing very small stones means that it is a case of cholecystectomy. No, it could be carcinoma of the head. Properly diagnosed dull aching pain could be due to cirrhosis, could be due to heart failure. I receive a lot of patients with heart disease and I refer them back to the cardiologist because of congestion of the liver and stretch of the liver capsule. Tiny stones in the gallbladder could be in pancreatic head tumors. Now, precautions. Operate physically fit patients. And go back to the principles of surgical practice for proper diagnosing of the cases like a physician. Chronic cough can cause dull aching pain in the right hypochondrium. As I said before, cirrhosis can cause also pain in the right hypochondrium. If any problem happened, then be calm and call for help. The first step in treatment, please be calm, call for help. Press the area, be calm and call for help. And the message number 11 here, call for help, and call for help. In open cholecystectomy, extend the wound and call for help. In laparoscopic surgery, convert and call for help. In small injuries, you can suture them around the T-tube. If you cannot repair a high injury, just put a drain and refer to a specialized center or to a specialized surgeon as early as possible. A delayed diagnosis, usually if the patient did not, as I said before, recover early. If he has lethargy, he has a problem. If he has abdominal pain, he has a problem. If he has nausea with or without vomiting, fever with or without rigors, probably you have to reinvestigate his biliary system for injuries. And if he has jaundice or bile leak, definitely has a problem. So early consultation and early investigation. And do not explore, even the consultant who is competent to do reconstruction should not explore before doing an MRCP to see the biliary system from above. Now, I stress on MRCP because in the previous lecture, people were denying the importance of MRCP. I think for our registrars, in the situations with our facilities in Sudan, we have to stress on importance of MRCP and importance of ERCP as well. And we know MRCP is excellent. It is sensitive. ERCP is not without complications, but it is quite helpful. For preoperative preparation of the patient, it is the principles of surgical practice for the fluids, antibiotics, and drainage of collections, control of infections, and these things, and correction of his proteins and his blood sugars and these things. And we have to stabilize the patient. And then we look for MRCP guidelines and protocols for safety of practice. I think the young working generation should develop their own guidelines for safety practice. And we should have a national registry for cholecystectomy. And it is another call also for surgical GIT specialty. Well, thank you very much. I have seen Mr. Ahmed Adam sitting with us in this session. I do apologize for the long session, but I would like to tell Ahmed, this is your friend, now he is a surgeon. Thank you very much.
Thank you very much, Professor Mohammed Ahmed, for this very nice elaborative session. Now it is the time for discussion. Anyone have any comment or any question, please unmute yourself and raise your hand to take the chance. Mr. Tamer Babikir, you're welcome.
Thank you, Professor, actually, for the elegant presentation. Thank you. We got enjoyed so much, actually, and I really got a benefit from this presentation, even more than the registrars. Just only I have a question about the timing of cholecystectomy with regard with the CBD stones and ERCP. Most of the time, the gastroenterologists, they are facing a lot of difficulty by doing the ERCP in a supine position. So if we are doing the simultaneous ERCP plus cholecystectomy, so they usually put the patient in his stomach, and then we are doing the cholecystectomy. Most of the time we found with the laparoscopy that the small bowel is very distended, and thus is decreasing actually the operative field and the proper cholecystectomy. So this is why, I don't know, sir, maybe I didn't reach actually your experience, but I don't like actually to do the cholecystectomy on the same session of the ERCP. Usually I keep it for the next day.
Yeah, true, you are right. I said either on the same day or next morning, or you delay it for something about a week or more. You are quite correct. There will be a lot of gases, but if you wait for 2-3 days, you will find also a lot of edema in the retroperitoneal tissue. It will make a nightmare for the section. So you are 100% right. But remember, I was talking about both open and laparoscopic surgery. Well, still, you can do it even in open cholecystectomy and even in laparoscopic surgery. And we have done quite a number. They do ERCP and then we take the patient on the same day or next morning for surgery. Probably the people who are doing ERCP are insufflating little gas. Probably we operate something few hours when some gas is absorbed and it passes away. But really, we have done some cases like this, either on the same day or next day. Or you wait for a week and then you operate. Because of tissue edema. Tissue edema makes life of the surgeon difficult. But you are 100% right. Bowel distended with gas is a problem.
Thank you, Professor.
But you know, also, the trick of putting an esophageal tube, things that have started classically in the early days of laparoscopy, that it is a must to put an esophageal tube, it is a must to put a Foley catheter. Now people are not putting it. Usually we are not doing like that. Urinary bladder will not be distended down up to the umbilicus in very few cases. And this should be diagnosed beforehand. And the stomach, the same thing. In fact, it is safer to go with Hassoun method, open method to insert the first port. It makes life easier for when you can insufflate gas and most the pressures in the abdomen.
Welcome, Mr. Ahmed Mohammed Adam.
السلام عليكم. شكرا لك استاذ بروفيسور محمد احمد معوف. حقيقي البيكتشر دي we are seeing right now very يعني lovely one. Thank you very much and كل التقدير لك في هذه المحاضرة القيمة. حقيقة يعني كانت سياحة ممتازة جدا بين الليكتشرز و journal club review, OSC station and even MCQs, and we enjoyed very much. Now I have 3 comments. Rather, number 1, regarding for the second part of MD exam, and I observed that most of cases of failure محصورة في improper history taking وما بكون في good clinical critical thinking and there is no clinical reasoning. يعني مهما كانت النوليدج أنا خليها the most important thing on exam is the evaluation of the ability of candidate to take a proper history and to do a proper examination. And this is my advice to young surgeons. I mean, you have to face a lot of patients and you take yourself the history and examination. خليها attitude. اي كيس نادوك له يا ريت ما تعتمد على الريفيرال بيبر ولا تعتمد على البيك اب كيس من الاي ار تحت. يا ريت الناس تتعود على المساله دي. This is number 1. Number 2, يعني you said a very good word regarding conversion. And I think conversion is success. Sometimes each hand might push you towards doing things and you need to succeed in doing laparoscopic operation without conversion. Like in the conversion itself, it's a success. If you face any difficulties, you have to stop and you have to think twice. أنا أتذكر كلمتك اللي قلتها ما بيخاف ما راجع. قالها لنا واحد من ال eminent professor of surgery in India إنه you have to be cautious and you have to be afraid for yourself, your career and for the patient himself. والحته بتاعت الهنري ريفرس سيلكس انا خليها هي من الحاجات المهمه جدا الناس تنتبه لها. طبعا اي دايسكشن above the sulcus انت you are safe. هي اللاند مارك اوف سيفتي ذات indicate the extrabilary landmark موجوده في 78% of patient. عشان كده ممكن تلقاها sulcus، ممكن تلقاها سليت، ممكن تلقاها عباره عن سكار، وفي زي 30 patient ولا 20 patient مرات بتكون ما فيش. انا خليها this is a very good landmark. My last comment about the chances of subspecialty for a young surgeon. Are you hearing me?
Yes.
أنا خليها subspecialties بقت very difficult للyoung surgeon to يعني progress in their career وكده. أنا أفتكر إنه a chances is within the faculties of medicine. It has to give a chance for young graduates to do a lot of subspecialty abroad. This is number 1. Number 2, a chance برضه في المينستر اوف هيلث. انا ما بقصد الفيدرال مينستر، انا بقصد وزارات الصحه الولائيه لازم تاخذ الانيشيتيف في انها تخصص معظم ابنائها الموجودين في الهوسبيتالز الكبيره في السيتيز دي. والحاجه الثالثه اللي هي السودان ميديكال سبيشاليزيشن بورد المفروض يكون عنده برضه الانيشيتيف، لانه كثير من البورد كثير من الكونسل توسعت كده، لكن ستيل في الجي اي تي we are looking for that. Thank you again for this elegant and fully elaborated talk, and hopefully we are going to see you again. Thank you.
شكرا. Thank you very much, Mr. Ahmed. Thank you very much. I think I feel you will have a good input for the registrars and the future of surgery in the Sudan Medical Specialization Board. I do support you, and I do support all people who are. And I think Mr. Sulaiman Hussein is here. And we sat together with other surgeons and we have passed the curriculum. Why it was not forwarded to the higher committees, I don't know. But the curriculum is ready, everything is ready, and people who are ready to train other surgeons. Anyhow, I hope during the period you are in the Sudan Medical Specialization Board, I'm sure you are going to push things forward. It was difficult years for the whole country, and for registrars also, and for us all. But I think when things become stable, you will do a lot of good for the Sudan specialization and for the future of surgery in Sudan.
Welcome, Mr. Mohammed Al-Fatih. Please unmute yourself.
السلام عليكم. شكرا بروفيسور للمحاضرة القيمة والمعلومات المهمة جدا الموجودة فيها. I have two questions for the registrars. When do they expect this operation is going to be difficult? How to anticipate a difficult cholecystectomy so that they can be prepared by calling a senior, by doing it in a good time so that they can get help when they need. So how to anticipate a difficult cholecystectomy? And the second thing, if they operate on a patient and they have a difficult cholecystectomy and unfortunately there is no one to help, what is the safest thing to do in that situation during surgery? Thank you.
Yes, registrars, Dr. Sadiq, Dr. Amin, if they are here, and others. These are very practical. I think the first question, I have touched on it. The answer should be clear. Predictors of difficult surgery.
Okay. For the first question, there is some predictors and issues to indicate that the gallbladder, the cholecystectomy will be difficult, like intrahepatic gallbladder and inflamed gallbladder with adherent to the omentum or walled off with omentum. This one of the features of difficult gallbladder. Very short cystic duct. For the second question, if you face the difficult laparoscopic cholecystectomy and no senior opinion around the operating surgeon, I think nowadays they initiate the bailout strategy. The bailout strategy is just try to do a minimal adequate for the sake of the patient safety. Like if it is difficult gallbladder and there is a stone in the common bile duct, in the Hartmann pouch or neck of the gallbladder, we can do just cholecystectomy and removal of the stone, or even closure of the just desufflation of the air, recording and desufflation without doing anything, and refer the patient to senior colleague. Thank you.
Anybody else would like to give his opinion of the registrars? A very practical question. How do you predict that in this particular patient, surgery will be difficult?
Dr. Amin, you are welcome.
Loss of recent memory is a characteristic of elderly people, probably like myself. But young people should remember what we have said in just less than an hour.
Hello. Hello.
Yes. Yes, please.
Thank you, Professor, for this precious and very rich. Hello?
Yes, yes, please. We hear you very well. Yes, go ahead.
Okay, I think male patients, whenever you are dealing with a male patient, you should anticipate that this should be a difficult cholecystectomy.
True.
And when you are dealing with elderly patients more than 65 years old,
true.
also, Yes, this is also a predictor that you are going to be dealing with a difficult cholecystectomy. Another thing is that whenever you are dealing with an acutely inflamed condition, this is also a predictor of difficult cholecystectomy being to be performed. A tender hypochondrium.
By ultrasound, signs of acute inflammation. Yes, proceed,
Yes.
go ahead.
Signs of acute inflammation.
Go ahead. Yes, you said males, particularly elderly males, and signs of acute inflammation. That is pain, tenderness, recurrent attacks of pain and tenderness, palpable gallbladder, or by ultrasound, they said it is thick wall with pericytic fluid and edematous, double wall like that. These are signs of severe inflammation. And as the previous speaker was talking that it is wrapped by omentum, particularly like cases of empyema gallbladder. And sometimes you find the perforation and covered by omentum. These are all difficult cases. It is true. The second question, what about the second question? What would you do if you do not find a pair of good hands to help you? If nobody responds to your calls, if you phone me, I was out of the station, or my phone was power off, or it happened, it was stolen, or something happened, or I was sleeping, and this is natural for any human being, and I did not respond. Then what would you do? And you are facing a difficult case.
Okay. It's just enough to perform a
very practical question.
To open the gallbladder and remove the stone and perform a partial cholecystectomy.
Partial. That is subtotal cholecystectomy. You remove all the stones, make sure in the cystic duct there is no stone, and you suture
subtotal cholecystectomy.
Gallbladder. Yeah, and put a drain. Right.
You suture the rest of the gall.
Is there any other thing you can do? If you couldn't do a fundus first cholecystectomy to end up with subtotal cholecystectomy.
You suture the rest.
Pardon? Subtotal cholecystectomy, any other procedure to do? If you couldn't do a subtotal cholecystectomy, you found it very adherent amalgamated tissues.
You can put a drain and refer the patient to the other expert surgeon.
Yeah. If it is descended, can you just put a cholecystostomy tube and come out?
Yes, cholecystostomy.
Just cholecystostomy tube and come out. If the gallbladder is gangrenous here or there, you can just leave, not leave it, isn't it? Do something, put something, any tube as a drain, and refer the patient after that. Drain the gallbladder itself. Yeah. So these are the things you do: a fundus first subtotal cholecystectomy, or you put a drain and bail out, as he said, or you drain the gallbladder itself by cholecystostomy. Any other question or comment?
Welcome, Dr. Aida Mustafa. Welcome. Please unmute yourself. Dr. Aida Mustafa.
They are bold and they are decision makers. I think this is especially the surgeons. They are bold and they are decision makers. And usually they can find a scientific way to defend their decisions. And I would like just to comment on what Mr. Ahmed said before. Particularly, I tried here to speak to the registrar and interact with them because the part of history taken, investigations and interpretation, the clinical competence, it goes with you for life. clinical competence goes with you for life. You should interpret each and every fact. If you can answer the question why for each and every fact, then you are super excellent. Yes, yes, please.
Good evening, everybody. I enjoyed very much the lecture by Professor Mr. Mohammed Ibn Auf. He is my professor and he's my teacher. And we used to assist him while he was starting doing, or while we are in the rotation. I hope he said that we can start our local training for doing this GIT and other specialties here in Sudan with this era of changes. I would like to ask some problems which can occur during doing laparoscopic cholecystectomy, that the port infection, it's very annoying to the patient and to the surgeon and difficult to treat. I would like also to ask about the Hassoun method. Do you prefer Hassoun method or the closed method? Thank you so very much, Professor. And I enjoyed the lecture very much, and especially the practical points, which we miss usually in the presentation. Thanks again.
Thank you very much. Thank you for your comments. In fact, I'm delighted really to see a lot of people are doing successful surgery, and they are doing advanced surgery that myself I am not doing. A lot of my colleagues now, some of them, they are doing bariatric surgery for obese patients. Really, these are smart people. They are very good. I think the future is bright for the generations of surgeons who are coming in all specialties, particularly in our GI specialty. I think a lot of people are doing a lot of things, which is really excellent and very good. Really, I am very happy for this. For port infection very easy to treat, but there is one organism. It is from the species of tuberculosis, but it is resistant to all drugs. You have written a paper on that. I will just try to remember it. I have written a paper about something patient. It is very difficult. Sometimes you excise the wound itself. It causes pain and it recurs infection, pain, infection. Usually there is no pus, but there is turbid fluid. We found that the cause is the poor sterilization. You see the theater attendants, after they sterilize the instruments, they put them in Sidex. And they clean them with distilled water. Never use distilled water for instruments of laparoscopy. Distilled water is distilled, but it is not sterile. It doesn't contain electrolytes, but it is not sterile. Never clean instruments. Never, if they are warm, put on them, put normal saline. Use normal saline, but never use distilled water. Distilled water can be mixed with sewages, and this bacteria, I would like just to remember it. It is a species of the tuberculous bacilli, very resistant to organisms. You use different antibiotics like this, but it's difficult. I have seen a lot of these cases. They are coming from other centers, and when they spread in a hospital, it is very nuisance to the surgeons. I think it happened in different hospitals like this. I will just try to remember the name of that bacteria. For Hassoun is a standard method. Now in the UK, all patients are operated with Hassoun. It's an open method. However, a lot of people in the USA, they use the closed method. Both are acceptable. The most important thing, when you insert the camera, first look for any injuries. And if the abdomen is virgin, not having any surgery before,
you can, I use a lot of blind insertions. But if there is previous surgery, then I have to go open method. It is a must to go open method. Anyhow, nobody can condemn Hassoun method at all. It is quite safe. It is quite safe method. But I will try to remember the bacteria that causes infection.
بروف البكتيريا هي البكتيريا atypical non-tuberculous mycobacterium كيلوني اسمها mycobacterium كيلوني.
That is it.
اتذكر انت عملت بيبر فيها واتذكر كان I faced with you a very tough pore infection you told me about.
Yes. Really very nuisant. يعني you excise the wound, it recurs again. You treat with different antibiotics, it recurs again. It takes very long time. I think it came to us from outside Sudan. We haven't seen it in my life. I haven't seen something like this, but in laparoscopic, fortunately, alhamdulillah, it didn't happen. No, it happened to me. It happened to me, and I seen it from, I think, at least 4 other hospitals. Like nowadays, it is not present. But the cause is that the cleaning of an instrument with distilled water. Tell the theater assistant to clean instruments with normal saline. If they are sterile and they would like to put any water on it, it should be normal saline, never distilled water.
If no more further question and comment, we are really special thanks to our eminent professor, Professor Mohammed Ahmed Ibn Auf, for this very nice and thorough discussion. And we hope
ممكن كومنت صغيرة يا محمد؟
جدا يا مستر طوالي.
معلش sometimes قلت لك الناس زي facing الكويشن يعني رامي وبروف نعوف جاوبوه عن التايمينج اوف cholecystectomy following ARCB. انا يخلي السمارت answer انه طبعا اي case should be treated as it merits. والرينجينج ده بيعتمد على الانديكيشن of ARCB. Sometimes you might do an ARCB in a very ill critical patient with permanent hepatic impairment. So those patients that might make more than 7 days even by putting a stent or removing the stone and so on. So the best thing that the art of selection, it lies between the patient condition and the indication for ERCP and the post-ERCP outcome, because you might end with a very difficult ERCP that's causing even a suspicion of retroperitoneal perforation and so on. So the selection صحيح السوبر سبيشاليتي بتاعنا الهيباتوبيلاري ممكن يقول لك 1 day 2 days 7 days، لكن in general for ESR the best thing is every case should be tailored in its treatment according to its merit. Thank you.
Yeah, that is wise. That is the wisdom itself.
Thank you very much, Professor Mohammed Ahmed Ibn Auf, for this very nice and informative session. And we hope to arrange another session in the next few days. We really enjoy this meeting, and also a special thanks to all the participants in this very interactive session. And we hope to see you in good health. Thank you very much, Professor.
Thank you very much. Thank you for giving me this chance. Thank you for all the attendants and for all the audience, and hope also to attend for them in their future sessions.
Thank you very much. Thank you, sir.